Yep. Good evening. This is Dr. Balaji here. I'm a consultant, critical care medicine, Apollo Hospitals, Chennai. The topic we are going to discuss for this evening is going to be non-invasive cardiac output monitoring. Okay.
Yes, sir.
We're going to see a brief introduction on a hemodynamic monitoring. Why we have to do a hemodynamic monitoring? Why not just a heart rate monitoring of a heart rate, ECG, and blood pressure is enough? When we have to do this complex hemodynamic monitoring, and what are the modalities are available, and how we are going to do that. So this is the physiology of the Frank-Starling equation, which we have studied in the physiology. So basically, the force of contraction, that is the ventricular performance, within the physiological limits, the force of contraction is directly proportional to the initial length of the muscle fiber, that is within the physiological limits. So as your length of your muscle fiber increases, your force of contractility increases. So this is within certain physiological limits. This is a physiological background behind preloading any particular patients. The more you give fluids, more the ventricular wall stretches. That is, the length of the muscle fiber increases. When the length of the muscle fiber increases, the force of contraction increases, the contractile state of the myocardium increases, it contracts in a better way. That is the idea behind giving fluid. But is it always the case? No, because the Frank-Starling equation starts with within the physiological limits. So what is this within the physiological limits? For the same individual, you can see various constructs of Frank-Starling equation. For the same individual, for example, a 70-year-old individual who wakes up from his house, his Frank-Starling equation will be something like this. When he goes to the park, starts his morning routine in the walking, probably his Frank-Starling equation will be like this. When he develops a myocardial infarction, ACS, acute coronary infarction, probably his Frank-Starling mechanism or curve will be something like this, where he may not be able to tolerate even minor fluid boluses. When appropriate intervention has been done, third day into the ICU, probably during the recovery state of the myocardium, probably the Frank-Starling curve may be like this. So within the physiological limit. So you can't keep on giving fluids. Why we can't keep on giving fluids? This is explained by this hybrid curve, which is a combination of two curves, which is Marik-Phillips curve as well as the Frank-Starling's curve. So you do have two patients here, which is patient A and patient B. There is a superimposition of two curves. The one is the Frank-Starling curve, the other one is the Marik-Phillips curve. So you do have a patient A here and patient B here. So here, in the two curves, you can see that when in the A scenario A, where when you resuscitate the patient in scenario A, when you give fluids, there is a large increase in cardiac output and there is a small increase in the extravascular lung water. But when they are in the steeper portion of the curve, but when they reach the flatter portion of the curve, then at that point of time, when you give fluids, then there is a small increase in cardiac output, whereas the large increase in extravascular lung water. What happens when there is a extravascular lung water? So excess of fluid is disadvantageous not only for the respiratory system, it virtually affects each and every system of the body, be it your central nervous system, be it your cardiovascular system, be it your liver, gastrointestinal system, kidneys, abdominal wall, endocrine, etc., etc., etc. So basically, overt fluid resuscitation is harmful. Okay. So now we have understood the why part. So why you need to have a complex cardiac output monitoring, because you can't keep on pumping fluids to your patient in ICU, because only 50% of the patient will be fluid responsive and you don't know your patient will be fit in which of the 50%. And second thing is the overzealous fluid resuscitation is going to be harmful. Then coming to the when, Then when the initial resuscitation fails, when you have mixed phenotype of shock. For example, if a patient comes with diarrhea with severe dehydration, then probably you can manage the patient with just a non-invasive blood pressure cuff. If the same patient comes after 3 days with septic cardiomyopathy along with EF of 40%, then probably you may need a slightly more advanced hemodynamic monitoring. So when there is a mixed phenotype of shock, you need probably advanced hemodynamic monitoring. Despite resuscitation, for example, when the patient has come to you with diarrhea with dehydration, you have resuscitated. Despite resuscitation, despite appropriate antibiotics, if there is a worsening organ dysfunction, when there is a lack of coherence between your macrocirculatory and microcirculatory parameters, probably at that point of time, probably that is an indication to use advanced hemodynamic monitoring. Or if there is any RV failure or pulmonary hypertension where your conventional hemodynamic monitoring may not be reliable. For example, your arterial line on all those conventional hemodynamic monitoring may not be reliable, then that is a situation where you have to go for an advanced hemodynamic monitoring. So this covers very few when indication of your advanced hemodynamic monitoring. So a brief overview. Our presentation is going to be based on one, what are the principles of our non-invasive hemodynamic monitoring? Two, how to construct that particular apparatus? What are the advantages of that particular modality? What are the limitations and what are the evidence? Okay. And what is the ideal cardiac output monitor? Yeah, ideal cardiac output is one which is non-invasive. Of course, all the modalities which we are going to discuss in the next 45 to 50 minutes are going to be non-invasive. It should be cost effective and cheaper. It should provide a continuous real-time automated measurements. Fast response time. If you give fluids, if you have to see fluid responsiveness, if you complete the fluid boluses, the response, it should have something called fast dose response time. If you give fluid now, the increase in cardiac output should be depicted by the monitor immediately and operator independent. Whether you are in the ICU or not, if you are on call, you call up your nurse, and if you ask her to give 100 ml of fluid boluses, if you ask her the number before and after giving the fluid bolus, if you are able to appreciate a change in number, and if you're able to decide whether you have to give more fluids or you have to start the patient on inotrope, that is the ideal cardiac output monitor. So it should be operator independent, and there should not be any need of any external calibration. Okay, so that is and there should be less inter or intra-observer variability. For example, if there are two intensivists, who is there? If two of them observe the same cardiac output monitor, if two of them observe two different results, then which means that that particular modality of cardiac output monitor has a lot of inter-observer variability. Okay, so is there any such monitor available? No, such monitor is not available. We have to invent such monitor it. Okay, so how will you classify the cardiac output monitors? Basically, invasive, minimally invasive, and non-invasive. So here we are going to concentrate mostly on the non-invasive cardiac output monitoring. And in particular, we are going to see on a transthoracic echo, bioimpedance and bioreactance, partial gas rebreathing, pulse wave transit time. These are the four modalities which we are going to see in the present discussion. Okay. Why non-invasive? Why can't we use invasive? Because one, PA catheter, yes, at some point of time, it is a standard of care in various ICUs, but it is associated with various complications, and the PA catheter cannot be used in certain pediatric patients. Arterial waveform analysis, yes, we can use arterial waveform analysis, but there are n number of studies which says that you should have a good arterial waveform and n number of ways to calibrate it. For providing getting a transesophageal echo, you need expertise, and that expertise should be available round the clock. And your esophageal Doppler is based on numerous assumptions. One such assumption is all the blood from the heart goes through your descending thoracic aorta, which itself is wrong. Probably only 70% of your blood goes through the descending aorta, and your blood is not laminar, it can be turbulent. So esophageal Doppler to start with is based on numerous assumptions, and it gives hemodynamic information only about the descending thoracic aorta. And the pulmonary thermodilution also, it is based on numerous assumptions, and validity, its utility is not useful in pediatric critically ill patients. Okay. So what are the modalities we are going to see? We are going to see transthoracic echocardiography, bioimpedance and bioreactance, impedance cardiometry, respiratory derived, that is partial CO2 breathing based on Fick's principle, and pulse wave transit time. Okay. So velocity time integral. We'll start with the simplistic measure, which most of us has used at various point of time. Okay, what is velocity time integral? So this image you would have seen in your ICU at various point of time. So this is a diagrammatic representation of a parasternal long axis view of the echocardiography. So this is your, if you keep your echo probe on the right side with the pointer towards your shoulder. Okay. So this will be your right ventricle, interventricular septum. Okay. And this will be your left ventricle and left atrium. And this will be your aortic valve. And this will be your mitral valve. And this will be your LVOT. So what happens when the left ventricular contracts and it ejects, the aortic valve opens and it ejects blood through the LVOT. When it ejects blood in the form of multiple cylinders. Okay. Blood gets ejected in the form of into aliquots of cylinders. So if you got to know the volume of these cylinders, and if you multiply the volume of these cylinders with your heart rate, then probably you will be able to calculate your cardiac output. So that is the geometrical bar physiological rationale present behind the calculation of this velocity time integral. So cardiac output is stroke volume times the heart rate. Okay. So it is based on the Doppler effect. So what is Doppler effect? Doppler effect is nothing but the apparent change in the frequency of the sound due to relative motion between your, either one of them is stationary, either the observer is stationary or the source is stationary, and the other one is moving, either the opposite one is moving. That is, if the observer is stationary, the source should be moving, or if the source is stationary, the observer should be moving. Okay, depends on the direction of your blood flow. For example, in this principle, say this is the probe, okay, this is the blood flow. If blood comes in this direction, for example, there are 5 probes here, okay. Probe number 1, 2, 3, 4, and 5, okay. So at this point of time, okay, when the blood reaches here, so blood flows towards the probe, it has a huge positive deflection, okay. But when blood flows here, probe number 5, it flows away from the probe, it has a huge negative deflection. Velocity. So the velocity depends on the strength of the returning echoes is directly proportional to the number of RBCs reflecting the USG. So more the number of RBCs, more the velocity. Okay. And the equation is given by the FD is equal to, that is a Doppler shift frequency is equal to 2 into transmitting frequency. V is equal to that is a velocity, which is a blood flow velocity, cosine theta divided by C. C is nothing but the velocity of the USG in the human body. Okay. This angle theta is nothing but the angle between the USG beam and the direction of the blood flow. And why we have to apply factor 2? Because as seen in this picture, your USG goes once and it comes back. So it is 2 cycles. So that is why we are using a factor of 2. So what we should know now is we have to know this velocity, because we are calculating a velocity time integral. If you want to calculate this, we have to rearrange the equation. So when we rearrange the equation, this is what you get. And the importance is the cosine theta. This cosine theta, so these are the various values of the cos theta. So the importance is when the cos theta gets higher and higher, your values get more and more obsolete. So cos 60, that has become 0.5. Okay. So that is why your angle of insinuation, it cannot be 0, which is way more difficult. So you should have an angle of insinuation of 30 degrees. So that is why the angle of insinuation should be at least 30 degrees. So what we are trying to do? So now we have got, if you have to calculate the volume of the cylinder, what are the parameters which is needed? Pi. Pi is standard. Everyone knows the value. R is nothing but the radius. So the radius, that is the valve area. The valve area everyone knows. So the aortic valve area can be calculated either from the parasternal long axis view, the same principle, echo phased array probe in the right side of the sternum, fourth intercostal space, slightly adjust on the right side of the sternum, and probe marker towards the right shoulder. And you can calculate the valve area. You get the diameter, divide the diameter by 2, you will get the radius, and square the radius. That is the valve area. And height. All we are doing, this is what we are doing here is we are calculating the velocity because we are trying to get the height of the cylinder. How we are going to get the height of the cylinder? Through the Doppler frequency, we are calculating the velocity time integral. Okay. When you integrate the velocity and time, velocity is nothing but centimeter per second. When you coalesce centimeter per second along with time, second and second will get cancelled. You will get the centimeter. The velocity time integral is nothing but the stroke distance. Okay. So you will get a stroke distance. So how we are going to getting it? We are going to get it through the putting a pulse wave Doppler in the aortic valve in the apical 5-chamber view. How to get apical 5-chamber view? So get a apical 4-chamber view, slightly angulate the probe so that you can open the aortic valve, put a pulse wave Doppler. When the aortic valve opens, put that sampling gate and you will get a nice VTA flows like this and trace it. Okay. So when we get sample like this, all types of shock, hypovolemic, distributive, cardiogenic, and obstructive, can affect your VTI. As far as hypovolemic shock is concerned, any VTI less than 18 may suggest that severe hypovolemia, you may have to give fluids. Extreme case of hypovolemia may produce this appearance termed as dagger appearance, suggestive of outflow kissing. This is the equivalent of kissing left ventricle or kissing papillary muscles, small chambers or hypovolemic chambers suggestive of severe volume contraction. Cardiogenic shock, if VTA is less than 18, then probably you may have to use some inotropic agents. Very rarely, it may be because of overt diuresis and patient can be still be fluid responsive as well. Distributive shock, usually VTA is more than 22. Very rarely, in the early phase of the septic shock, patient can still be hypovolemic. In obstructive shock, if VTA less than 18 with RV failure or tamponade or tension pneumothorax. Okay. Pros and cons. What are the advantages of using VTA? One, nowadays, echo machine is a standard of care. Ultrasound machine is available in all the ICU, so it is bedside, it is reliable, it is simple, cost effective. It is feasible in up to 70% of the patient, and you can always resuscitate a patient. You can give them a fluid bolus. You can do a repeated measurements. Disadvantages, you have to get a window. The angle is very important. We have seen that we are using cos theta. Any angle more than 30, if your angle more than 60, then cos 60, then your value will become altered. We have seen that the cos 60 is 0.5 and it is present in the denominator, which means that the value will get doubled. And subaortic obstruction, LVOT obstruction, extreme hypovolemia, asymmetric LVH, these situations, what happens is it produces a very altered VTI wave pattern. Okay. And it is operator dependent. It is highly operator dependent. Your nurse may not be able to do it. You have to do a in case if you want to assess a cardiac output by this method, you may have to do it. It is load dependent. What is load dependent? It is preload dependent. If patient is extremely hypovolemic, if you resuscitate the patient, probably patient have show improved response. Okay. Dynamic LV outflow tract obstruction in AR produces high LVOT velocity. So false positive VTA may present in dynamic LV outflow tract obstruction and AR. Okay. So these are the in case if you want to do a passive leg raising test without changing the angulation, such kind of fixating devices are available. So this shows the importance of the LVOT diameter. Any miscalculation in the LVOT diameter, please do understand that any miscalculation may get squared because the volume of the cylinder, your pi r squared h. So r squared, any miscalculation will get squared. So your angulation is important. Your calculation of the aortic valve dimension is very important because your mistake will get squared. So this completes the first modality, which is your velocity time integral. So a brief overview, velocity time integral is very simple because USG machine as a standard of care is available in most of the ICUs. And initially, you have to do a parasternal long axis view, pick up the, either you can use a normogram for the calculation of your aortic valve area, or you can use a calculate the aortic root diameter, divide it by 2, then square it. Then apical 5-chamber view, open up the aortic valve, make sure your angle of insertion is less than 30 degree. Then put a pulse wave Doppler, get a nice velocity time integral waveform. Then calculate the VTI. Then calculate the stroke volume, and cardiac output is equal to heart rate times the stroke volume. And do remember all the disadvantages. Coming to the bioreactance and bioimpedance. Okay. Bioimpedance refers nothing but the measure of the opposition of the electrical flow. Okay. It is nothing but the resistance. So if this is the electric current, this is the resistance. So here measures the change in the thoracic voltage amplitude in response to the high frequency electric current. It starts way back in 1960. The first usage of the impedance cardiographic measurement of cardiac output starts with the use in the National Aeronautics and Space Administration in Houston, Texas. So what they have done is they have used 4 electrodes, 2 bands in the neck, third in the xiphisternum, and fourth in the lower abdomen. They have passed a 6 milliamp constant sinusoidal current, and what they have measured through the external electrodes, and through the internal electrodes they have measured the impedance, and they tried to calculate the stroke volume. How? We will see. Let us assume that our thorax is this cylinder and you are passing a electric current. You know the quantity of this electric current, which is I, and which is known amplitude and known frequency, and you know what voltage you are measuring here, which is V. Okay. So we, by Ohm's law, we know that V is equal to I times the R. So if in case if you want to know the resistance, R is equal to voltage by current amplitude. This resistance is proportional to the amount of fluid. How? We'll see. So by the same principle, if you apply Ohm's law to the cardiac output, we know that cardiac output is equal to the systemic filling pressures. That is the mean arterial pressure minus central venous pressure. Pressure at 2 ends of your circuit. That is, mean arterial pressure is the pressure head at the arterial end. Central venous pressure is the pressure head at the venous end. So difference in the pressure head at the 2 different ends divided by your systemic vascular resistance. Okay. So impedance is equal to voltage by current. It is inversely related to the thoracic fluid content. Why it should be inversely related? We'll see. When the heart contracts, it ejects blood. Okay. So all the blood contains hemoglobin. Hemoglobin RBCs contain hemoglobin. Hemoglobin contains iron. So the iron, it conducts electricity. So when the iron conducts electricity, it decreases the resistance. It favors the conductance, thereby decreases the resistance. So it decreases the impedance. So that is why the basal impedance is inversely related to the thoracic fluid content. Okay. So this cardiac cycle induces changes of the electric impedance of the aorta. The change in the electric impedance is proportional to the change in the volume of the thoracic aorta. Okay. So initially, the current is passed between the outer electrodes, and so the current is passed between these outer electrodes. What it does is it chooses the finds a pathway of least resistance through the low resistance compartment. It chooses the pathway of least resistance. So what pathway it chooses? Obviously, it goes through the blood fill compartment, which is the heart and the great vessels. So during systole, what happens? During systole, blood is ejected from the ventricles into the aorta, and it distance transiently, increasing the volume of the low impedance compartment and increasing the electrical conductivity of the thorax. And the baseline impedance and change in impedance are measured by these inner electrodes. The outer electrodes transmits the currents, and the inner electrodes measures the current. It measures the baseline impedance and change in impedance. So this baseline impedance is inversely proportional to the volume of the conducting fluid and thoracic conductivity. Okay. And the change in impedance is measured from the baseline impedance, and cardiac origin is apparent when they compared it with the ECG waveform as well. So this is what exactly happens. So when they give the current, this current chooses the pathway of least resistance. This least resistance is obviously through the pathway which contains the blood. Okay. Systole, when the blood is ejected, there is an increase in conduction, decrease in impedance. So this baseline impedance and change in impedance will be calculated. The baseline impedance is inversely proportional to the volume of the conducting fluid. For example, if I have a lot of blood, I will have a lot of iron content. So I will have a more iron to conduct my electricity, so I will have least resistance. So my baseline impedance is inversely proportional to the volume of the conducting fluid. So based on that, they do have arrived at the equation. So the equation is consist of these three components. So the VEPT, stroke volume, is equal to VEPT, that is volume of the electrically participating tissue, times VET, which is a ventricular ejection time. This ventricular ejection time is taken up from the RR interval in ECG, and EPCA, which means ejection phase contractility index, which is indirectly proportional to the thoracic electrical bioimpedance. To do this calculations, they do have some assumptions. Okay. What are those assumptions? Aorta is not the only thoracic fluid containing compartment in the thorax. Okay. For example, there can be pericardial effusion, there can be pleural effusion, there can be chambers of heart filled with blood. Okay. There can be conducting vessels, which means capacitance vessels, which means there can be SVC, part of IVC. Okay. There can be part of a small part of jugular vein which comes and joins the SVC. So majority of change in bioimpedance is due to aortic blood flow. That is a first assumption. And changes in capacitance vessel blood and microcirculation vary little with respiration. And dt by dt max corresponds to peak aortic blood volume. Systolic ejection time can be measured from ECG-RR interval, and EPCA is equal to the ejection phase contractility index is equal to dz by dt multiplied by total fluid conductivity. Finally, VEPT can be predicted using patient demographics, gender, height, and weight. Okay, electrically conductive tissue can be conducted from patient's demographics. Okay, so based on this, they calculate the bioimpedance and bioreactance. So based on this, so two devices are available. There are a number of devices. The two devices, what are the devices available? NCOM, BIOS, that NCOMO, ICON. So these are the various devices available. Okay. The ECOM monitor and the ECOM tube is peculiar among this because here the transmitting and receiving electrodes are located in the cuff of endotracheal tube, with the assumption that it will be present close to the ascending aorta. So the signals from the other areas can be minimized. Limitations. So low signal to noise ratio, interference with electrocautery, factors affecting the accuracies like patient movements, arrhythmia, improper electrode placement, and affected by temperature and humidity of the skin. So the evidence are not great. Okay. Numerous studies have shown that bioimpedance should not be used in the critically ill populations. So bioimpedance per se is not used in the critically ill population. So it is not valid in critically ill patients. So what is the next step? They has gone to some fine refinement. So how we transition from AM radio to FM radio, they have transitioned from Similar to a change in resistance, a change in capacitance and inductive properties happen. More robust technology is available. Okay. So rather than change in amplitude, which is bioimpedance, what they are observed, they are observing change in phase, which is the bioreactance. Why bioreactance? Which carries a better noise filtration ability. Okay. So what about the bioreactance? So bioreactance has some reasonable evidence for use in critically ill patients. So in addition to the change in resistance of the blood, the change in intrathoracic volume also produces change in the electrical capacitive and inductive properties. Techniques for detecting relative phases are inherently more robust. Okay. So this multicenter study has shown good correlation in cardiac patients, and this prospective single center study in 110 post cardiac surgical patients has shown that the reported bias is very minimal. It was close to 0.16 liters per minute, and the level of agreement is good, and the precision was better than that of thermodilution. And here also the NICOM, which is the bioreactance and auxiliary devices, similar monitoring capabilities in post-op cardiac surgical patients. When they compared NICOM and PICO, it is comparable to that of PICO monitors. So in this study, what they have done is they have compared patients with pulmonary hypertension. They have used three different devices: thermodilution, bioreactance, along with that fixed principle. And here they have used non-invasive bioreactance-based passive leg raising to assess the fluid responsiveness. So compared to bioimpedance, bioreactance has decent level of evidence as compared to the it can be performed in both ventilator and non-ventilator patients, can be used in patients with arrhythmia, relatively easy to set up, less interference with electrocautery, can be used in ER, OR, and ICU. Okay, this is one of the very few algorithms used in bioreactance. Impedance cardiometry is a slight modification. It is based on the change in orientation of the RBCs. Here, the number of electrodes is slightly less, 2 electrodes in the neck and 2 electrodes in the left side of the thorax with 15 centimeter gap. Neck, thorax, 15 centimeter gap. It is based on the orientation of the RBC. During diastole, all the RBCs are haphazardly arranged. When heart contracts, when during systole, all the RBCs are linearly oriented. When the RBCs are linearly oriented, the conduction of the electricity is better. So this pulsatile flow, there is an alignment. When there is an alignment of erythrocytes, then there is a better conduction of electricity. So by analyzing the rate of change in conductivity before and after the aortic valve opening, how fast it indicates that how fast the RBCs are aligning. So this impedance cardiometry says the peak aortic acceleration time. That is the ventricular ejection time. From the ventricular ejection time, it derives the stroke volume. Okay. So these are the various monitor which uses impedance cardiometry. These are the various parameters available with ICON. Even though the trend observation is satisfactory, as of now, it cannot replace thermodilution or transthoracic echo at this standpoint. So what we can do regarding the bioimpedance and bioreactance? One, we'll try to box the heart. Demography is very important because there are three parts of the equation. Okay, demography is very important. Tegadam above the electrode increases the life. Okay, if there is any electrical devices, always try to go away from the electrical devices. Clean and dry skin is very important. Yes, you can do chest X-ray or a CT, but MRI is not compatible. Okay. Coming to the fourth one, which is the partial CO2 rebreathing method. It is also a non-invasive device. Okay. And it is a multi-channel device. Why it is called multi-channel? Because it has a mainstream infrared CO2 sensor, airflow sensor, and it has a SpO2 monitor. And it needs patient on an endotracheal tube and partial rebreathing technique. Okay. So it needs patient to be an endotracheal tube, and it is based on partial rebreathing technique. It is based on fixed principle, a differential fixed equation, and it is based on law of conservation of mass. What is the law of conservation of mass? Before the reaction and after the reaction, the total mass of LHS and RHS should be equal. Okay. So before and after the reaction, the total mass should be equal. In case if there is some loss of mass as energy, if you can add that energy should be equal. So there is a law of conservation of mass. So before advent of the PA catheter, this fixed principle of the cardiac output measurement is used as a gold standard. Okay. So the total uptake or release of substances by an organ is equal to the product of blood flow to the organ and the arteriovenous concentration difference of the substance. This is what fixed principle is all about. So basically, initial fixed principle is based on the VO2, cardiac output is equal to VO2 divided by CaO2 by CvO2. This is what the cardiac output. So this is O2 consumption. This is arterial content of oxygen. This is the mixed venous content of the oxygen. But here the consumption of O2 calculation is very cumbersome. You need an ABG. And in ideal fixed equation, it is calculated from the left atrial sample in animal studies. Here you need a mixed venous sample. So that is why here it is calculated, since it is very cumbersome to take direct sampling from all those things. We have started using CO2, and that too we are avoiding invasive method because now we have a EtCO2, and the EtCO2 we are assuming that there is a equilibrium between your PaCO2 and EtCO2, and we are calculating that from your carbon dioxide dissociation curve through DIS devices. So here what happens? Here you have a anesthesia and YP circuit where you have a NICO rebreathing loop. At times you will have a CO2 production is calculated as a product of your CO2 concentration and an airflow during a breath cycle. And your arterial CO2 content is calculated from your EtCO2 and from a CO2 dissociation curve. And every 3 minutes, you will have a partial rebreathing state using a loop. During that time, there is an increased EtCO2. And you have to assume that cardiac output does not change between your normal and rebreathing state. And using a differential ratio, you will calculate a cardiac output. So this is a normal breathing. This is the rebreathing. So you can see that during a rebreathing, your EtCO2 goes up. So this is how they derive the differential Fick equation. What are the advantages? It is easy to use. It is automated. It is clinically acceptable. It is compared to transpulmonary thermodilation, cheaper, doesn't need expertise. Limitations, since it is based on fixed principle, whatever the limitations of fixed principle, it will apply to this partial rebreathing technique as well. Fixed principle assumes that left ventricular output and right ventricular output is equal, which may not be in all scenarios. In case of intracardiac shunt, it is not reliable. If there is low CA-CV difference stage, it's not reliable. Hyper and hypometabolic states, for example, malignant hyperthermia, hyperpyrexia, is not reliable. Patient in severe, for example, if you're using a therapeutic cooling for some reason, it may not be reliable. And what are the inherent limitations to the technique? It should be leak proof. If the non-ventilated patients, it may not be reliable. If the patient is having a leak tracheoesophageal fistula, or if he is having a alveopleural fistula, bronchopleural fistula, it may not be reliable. Not suitable for patients with severe pulmonary disease. The entire principle is based on appropriate equilibration between your EtCO2 and your PaCO2 value. When there is a severe pulmonary disease, that equilibration gets lost, so it is not reliable. Not suitable for pulmonary hypertension, high ICP, and severe AIDS patient who may not tolerate even a small rise in EtCO2. Rebreathing and not rebreathing cycle, no immediate response can be expected. and sudden release in CO2. For example, if the patient is undergoing surgeries like complex vascular procedures, use of tourniquet or aortic cross clumping, sudden release of CO2 happens, it may not be reliable. Okay. So this question paper says that the accuracy and precision of the cardiac output monitoring using fixed principle is may not as good as we think. The final one is the pulse wave transit time. What is pulse wave transit time? It goes by the name. The pulse wave transit time is the time required by the pulse pressure to travel between the 2 points. So the pulse wave goes, it's a pulse wave transit time. It's a difference between the R wave on the ECG and the rise point on the pulse oximeter. It is inversely proportional to the stroke volume. So if the stroke volume is good, which means that the pulse wave travels to between 2 points very rapidly. If the stroke volume is very small, it goes very slowly. In final year MBBS, you would have heard something called parvus et tardus, slow rise and late peak, which happens in a stenotic valvular lesions, which means that those stenotic valvular lesions will have a low cardiac output state. Stroke volume will be very low. So you will have a slow rise and late peak of pulse. So if you apply the same principle here, you can understand this. Assumptions. What assumption you are making? Your systemic circulation is a three-component circuit, which includes arterial compliance, aortic impedance, and SPR. Okay. So this is the ECG and this is the so here the pulse wave reaches 30% of the peak, and you do have a various time points, which is T1, T2, and let us dissect and see the individual time points. Okay. The PEP, which refers to the it refers to the electromechanical delay at the start of the systole and the isometric contraction with the R wave of the ECGs at the starting point. If the PEP is shortened, which means there is an increased contractility. If there is a short PEP, which means the contractility is increased. What about the T1? T1 is a time taken by the pulse wave to travel from the aorta through the elastic arteries to the muscular arteries. So reduced compliance, there is a short T1. What about the T2? T2 refers to the time taken from by the pulse wave to travel from the muscular artery to the distal peripheral side. If there is a reduced vascular resistance, low SPR, there will be a short T2. So this particular monitor uses the pulse wave transfer time. Advantages: uses only ECG and plethysmography, non-invasive technique, demographics data which should be available. Pitfalls: initial calibration is based on a crude algorithm. Intra-patient variables are there, not validated critically ill. Often requires a external calibration. In case of cold periphery, reliability is not there. Okay, and it is not reliable in case of arrhythmias, volume hypovolemic states, use of vasoconstrictors or vasoactive agents or vasodilators. Okay. So in critically ill patient, the performance of pulse wave transfer time monitor is not clinically acceptable and it is not recommended at the current standpoint. The same goes with this study as well. It is not recommended to assess intraoperative fluid responsiveness. So ideal cardiac output monitor should have all these characteristics. So accuracy. So accuracy is nothing but the accuracy of the individual measurements to the reference standards, and the precision is the random error assessed by the closeness of agreement between the same or similar objects. Example, if you are making repeated measurements, the first value and second value should agree with each other. That refers to the precision. Okay, and the same goes with the reproducibility and repeatability and step response change. Step response change refers to the time gap between the intervention and the response. And trueness refers to the agreement between the measurements and the reference value. For example, if you take PA catheter as a standard value, and if you're using the pulse wave transit time, how far these two values agree with each other, that refers to the trueness. Okay. And these are the various analytical methods which you can use. The most frequently used analytical method in evaluating the cardiac output monitoring devices is the Bland-Altman method. and plotting the bias against the mean cardiac output and determining the LOA means the limits of agreement. Okay, the percentage of error is calculated as the ratio of the two standard deviation of the bias to the mean cardiac output. It will be considered clinically acceptable if it is below 30%. Okay. Yeah. Thank you.